We want to welcome you to the first webinar of our series.
This meeting is being recorded.
We want to welcome you to the first webinar in our series focused on implementation of person-centered, respectful care interventions across the life course in Africa. This series is hosted by a collaboration including Kambuzu University Health Sciences in Malawi, University of Nairobi in Kenya, Makerere University School of Public Health in Uganda, and the Implementation Science Collaborative. This is which was launched with support of USAID, the UCSF Advancing Maternal, Neonatal and Child Health Group, and the East Central South Africa Health Community. This webinar series will confer CPDs for all participants. Once you register, you will receive a code which you will use to earn your CPD points. But you must have attended at least 30 minutes of this session. So you're most welcome. Let's start off by our first presenter, who is Dr. Drelis Walker. Just a brief bio about Drelis. Dr. Walker works jointly in the Obstetric and Gynecology and Global Health Science Department at UCSF. Dr. Walker is also affiliate faculty at UC Berkeley and a visiting professor in reproductive health at the National Institute of Public Health in Mexico. Her principal research involves implementation trials addressing issues related to quality of antenatal and obstetric care, designing and implementing innovative provider training strategies using highly realistic simulation and team training, as well as group models of antenatal care. Dr. Walker directs the Maternal Newborn Health Research Group at UCSF and is president and co-founder of Pronto International, an NGO dedicated to making birth safer for mothers, infants, and their providers, and serves as a principal investigator on four global maternal and neonatal health focused grants. Dr. Walker collaborates with partners in India, Kenya, Uganda, Mexico, and Guatemala. She will be our first presenter, and she'll present on landscaping review of respectful maternal care interventions in Africa.
Great, thank you so very much. And it's really a pleasure to be here with you, which is what your afternoon and my middle of the night. So it's really great to be here. I will put my camera on so you can see me briefly, and I can send my well wishes from San Francisco. As I said, it's great to be here with my colleagues from Kenya, Uganda, Malawi, to represent this work and introduce you to this series that we're planning. The Implementation Science Collaborative, and I'm trying to get here to, is a partnership that advances the use of evidence to improve policy and program implementation in a whole variety of areas. The work we're doing here with you today is related to our women-centered care domain, and that includes the respectful maternal care as well as postpartum hemorrhage. There's a number of other areas that the Implementation Science Collaborative is active in, and that is supported through USAID's Health Evaluation and Applied Research Development Project. So I just wanted to share that with you in case any of you are interested in some of the other topic areas, and to let you know that there are a number of other events and webinars. I'll tell you about one at the very end of this brief presentation. And we have programs in a number of countries around the world. So let me just set the stage for you for what, as our moderator said, is we're launching a mini series on person-centered care. And as you are all well aware, person-centered care is something that is important throughout the life course. And we will be looking at it through those various lenses, including family planning, during pregnancy. And today we're going to be talking about respectful maternal care during childbirth. It's also relevant in the postpartum period and in the newborn, in terms of newborn care. So today, what I'm going to do, I'm going to share with you a landscape analysis we did of respectful care interventions or interventions to promote respectful care at the time of birth. And then my colleagues and others will be sharing some more detail about specific interventions. To do that, it's important that we put the whole history of respectful maternal care and why and how we're speaking about it today in a broader context historically. This all pretty much began in 2010, so just over a decade ago, when a landscape analysis came out from the Traction Project, which looked at what is the evidence for disrespect and abuse and what is going on in labor and delivery units across the globe. That then informed research and advocacy framing that provided us this typology of disrespect and abuse. So we're talking about a whole variety of domains that include non-dignified care. Are you seeing the wrong screen here? I'm just recognizing as are you sharing or am I sharing, Agnes?
We can't see anything on the screen.
You can't see anything?
I think
yes.
it's okay. We can see it.
Okay. Let me just try one more time here. And you can tell me what you're seeing now. What do you see?
Global recognition of 2 ecosites of quality.
Perfect. So that's right where we're supposed to be. As I just mentioned, there's the historical framing from the Bowser and Hill report that led to us thinking about, now that we know how to speak about it and what it is, what are interventions and how do we look at interventions? And this was pushed along by WHO's vision for quality of care in terms of their presenting quality of care through the system lens of having provision of care or the evidence-based practices that are used in parallel and on equal footing with experience of care. And this is where respectful maternity or maternal, both are equivalent, fits in. And the World Health Organization has since come out with a number of policy statements as well as guidelines and standards for what women should be expecting during childbirth. And I think you all will know very well that there are a number of factors that contribute to disrespect and abuse. It includes lack of support, mentorship, and supervision, poor infrastructure, insufficient training, just insufficient health workforce, not enough people around. Patients also have low expectations and knowledge of clinical care that they should be receiving. And there are issues of patient-provider interactions or relationships. So this is not a turn the switch topic. This is a complex, multifactorial, multi-domain, and there are many, many pathways that lead to the experience of care. So what led to the landscaping work that we did? As I mentioned, prevalence, incidence, and etiology of disrespect and abuse has been documented, and there are a range of interventions have been developed. However, policymakers that are interested in respectful maternity care lack the information and evidence they need to understand which interventions should be implemented. So different terms and frames are often used to contextualize respectful maternity care, and that may actually hinder or obscure progress because we're talking about this in so many different ways. So we set out to identify and disseminate a summary of promising approaches and existing evidence on respectful maternity care interventions, not defining it or naming it, but how are we trying to improve it, and specifically what occurs in Africa. This began by a literature search, and I just wanted to share with you briefly what came up in titles and abstracts. We looked for these 4 terms: experience of care, mistreatment, disrespect and abuse, and respectful maternity care. And you can see by this figure that over the last decade, there has been a real explosion in the topic area. So this is something that is becoming more and more prominent in the literature. And also there has been a bit of a shift in terminology, with respectful maternity care really being in the lead and shifting less from speaking about disrespect and abuse. It's still very important. On the right, you can see how these publications corresponded with some of the most significant advocacy policy statements from WHO and others that have led to the prominence that this currently has for clinicians and policymakers. In terms of the actual interventions, we found 43 distinct interventions across the continent of Africa. And we found them in the published literature, the gray literature, and crowdsourcing. And as you can see in the figure, most of these interventions have been concentrated in East and South Africa primarily, with the greatest number being from Tanzania, where there has been the most activity in this area. You can also see that this has also been something that in the last few years, there has been more and more of. We're going to hear today from some interventions, I guess, haven't even made it into the literature yet. And I think this is an important area to keep our eye on. We took those 43 interventions and we divided them or categorized them into different domains or types of approaches. And we split them. These here are the demand side approaches. So things like training healthcare personnel, facility levels improvements, making privacy more accessible. There's also a whole area of interventions around supporting the wellness of providers. And we're hearing more and more about the importance of caring for carers, which I believe many of you are. And I personally think that this there's a wealth of information that we need to, or things we need to do, as well as things we need to learn. Implementation of quality improvement programs. Many of you have been involved in QI, and there are focused QI efforts on respectful maternity care. And then there's government and policy drivers of interventions that can promote this. Then there's the supply side, which are advocacy efforts for respectful maternity care, educating birthing persons, and then finally engaging community members and other actors that can help push the demand for respectful maternity care. And I think I misspoke. Remember, it is 4 o'clock in the morning here. I think that the left side are supply side and the right side are demand. So the supply side interventions and the demand side interventions. And then finally, there are these social accountability mechanisms, including scorecards and voice and action. So those 43 interventions that we found, how do they pan out? Most of them involve supply side approaches, where we're talking about training healthcare personnel is the #1 most important or most prominent of the interventions. And you can see there are 2 bars. The top bar represents an intervention with a single approach, and the bottom bar for each of those represents an intervention with multiple approaches. So you can see most of the interventions were not single approaches. They included different types of interventions that included supply side elements and or demand side elements. And the most prominent is training, both as a component of a package of interventions, as well as an individual approach to improving respectful care. And I think, here we are today in a training. It's important we look at what those, a little bit of a deeper dive into those trainings. So we found that of the 20 interventions that approached this through training, we found that just over half of them involved both clinicians and non-clinical workers. I think this is important that we think a little bit about who should be the target of these trainings and the importance perhaps of a multidisciplinary approach. The format of the training, most of the interventions that we were able to find information about did not specify the type of design, but there are a significant number, you can see 6 here, that use an interactive design with role plays. And then finally, how often or what kind of frequency or dose of training are these interventions using? And just slightly more than the others are using sort of a consecutive series of trainings with ongoing mentorship and support. You can see 8 of those that involve that, followed by a multiple day intervention sort of at one sitting, and the others that we really don't know much about or are a single day. I think this importance of recognizing perhaps this is something that is not that might take multiple dosing in order to actually change behavior. So let me end by just sharing with you what the key messages that came out of this landscaping work. As you've seen over the last decade, there's been a real growth in the publications in this area, and respectful maternity care is the lead terminology that's being used generally. In the landscaping work, we found that most of the work is concentrated where I believe most of you are joining us from in East Africa, and a significant number in Tanzania. As we heard at the very beginning, this is I'm representing the Implementation Science Collaborative. We're also working with EXA, which is the East Central South Africa Health Community, which will be hosting another webinar later this year, probably in May, diving into those interventions in Tanzania. So keep your eyes open for that. Most approaches, as I mentioned, focus on training healthcare personnel and facility level improvements. I want to emphasize, and I hope that we'll have some rich conversation at the end around what actually does it take to provide respectful maternity care, and is this emphasis on training and putting up curtains the appropriate and where most places should be focusing at this point. And this idea that interventions need to be multi-component and address some of the different domains that are driving respectful care or disrespect and abuse. It's important to note that I didn't say anything about the effectiveness of these interventions. What works? We looked for indications or measures of effectiveness, and really this is not being reported in the reports that we were able to uncover. And I think that as a community, and again, I'm very interested in hearing inputs from you, we need to better define what are some of the shared indicators that would be important to you to be held accountable to, or to be measuring if you're a policymaker management, in order to be able to assess impact. And this idea that if people are thinking about designing interventions, it may be that multi-component interventions are more likely to result in change as they address the different pathways and components that may be impacting respectful care. So with that, I'm going to end. I do want to just give a quick announcement that our next webinar in this series for person-centered care is going to highlight the work of Innovation for Choices and Autonomy, also known as ICANN. And this is a project that is aiming to optimize the approaches to implementing self-injectable Depo-Provera within a full basket of contraceptive choices, and to answer crucial questions about how self-injection can enable contraceptive use for women. So keep your eye open for that. That will be coming up probably in May. And finally, I just want to acknowledge our funder from USAID for this work and point out that if you have any interest to learning more about either Advancing MNH, you have the website there, or the Implementation Science Collaborative. Thank you. I'll turn it back to you, Raheli.
Thank you, Dr. Walker. I would not agree with you more that we need to train more health care personnel to give respectful care to our clients. And we also need to ensure that we have adequate supply and equipment as we do so. So I don't know, I've not seen Dr. Martha Kamanga. Has she joined us?
I believe she's there, yes.
Yes, she is, Dr. Martha.
I have seen her. So our next presenter is Dr. Martha Kamanga, who is currently the head of department for midwifery section, a senior lecturer and a researcher for Kamuzu College of Nursing, part of the University of Malawi. She's a registered nurse midwife with Nurses and Midwives Council of Malawi. She received her PhD in nursing from University of Illinois, Chicago, and her master's in sexual reproductive health from the University of London. Dr. Kamanga is very experienced in generating evidence for STI or HIV, adolescent, maternal and neonatal health. She is a co-investigator on the APPHC study titled Implementation Research on a Provider Behavior Change Approach to Overcome Social Normative Drivers that Impact on Quality of Postpartum Hemorrhage Care in Malawi. Welcome, Dr. Martha Kamanga. She'll be presenting her work on the Advancing Postpartum Hemorrhage Care project. Dr. Martha Kamanga, can you hear me?
Rahel, she's still on mute. We can go on to the next presentation. Yes, Rahel, we can hear you. We can hear you. Yes, I think she's still on mute. We can go to the next presentation as we try to assist her to join in as a panel.
Oh, okay. So our next presenter is Elizabeth Aya Bere. Elizabeth, you're there with us?
Yes, please. Allow me to share my slides, please.
Okay, Ms. Aya Bere is a midwife and lecturer at the Department of Nursing at Makerere University, Uganda. She has worked as a faculty and clinical instructor in midwifery and pediatric nursing specialties for over 10 years. She's the country principal investigator for NIHR, a global health research unit on stillbirth prevention and management in sub-Saharan Africa and South Asia, in collaboration with the Liverpool School of Tropical Medicine. In addition, she's a mentor and a leadership coach for the ALERT project, whose aim is to improve intrapartum care by positioning midwifery within the maternal healthcare continuum. She's a member of Sigma Theta Tau International Nurses Honor Society and the deputy country lead for LAMRAN Kenya, which is Lugina Africa Midwife Research Network. Uganda, sorry. Ms. Aya Bere has worked with nurses and midwives in Uganda to improve care for patients through clinical audits, skill training, leadership coaching, and mentorship. She holds a Bachelor of Nursing and a Master's of Nursing in Midwifery and Women's Health degree from Makerere University. She received a postgraduate diploma in child nursing from the University of Cape Town, South Africa. Currently, she is pursuing her doctoral studies with a focus on intrapartum care and interventions to prevent and manage birth asphyxia in northern Uganda. She will be presenting her work on respectful maternal care interventions in Uganda. Welcome, Elizabeth.
Thank you so much, Raheli, and good afternoon or good morning to everyone who is listening to us. I've been well introduced, and my contact, my email address is on the screen. Please, you can take it. So I'm going to talk about opportunities and challenges of implementing respectful maternity care in low resource settings. And I will draw my insights from the ALERT project that we are implementing in one of the regions in Uganda, in Eastern Uganda. So I thought that I would put some objectives and just to define what respectful maternity care is in the context of intrapartum care, in case some people are not familiar with it, and looking at the components. I know that Drelis has touched a bit of this, and then we look at the typology of disrespectful care. What has been found out, and then we look at some of the challenges and opportunities for implementing respectful maternity care, and I will then share what is happening within the ALERT intervention. So respectful maternity care refers to organized care that is provided to all women. And the keywords are that this care should give the woman dignity. She should have privacy and confidentiality. She should be able to make informed choices and have continuous support, but also be free from harm and mistreatment. And this is a right for every woman, regardless of your status, of the birth setting, the cadre of the provider, and also the level of income that you're coming from. So these are some of the components of respectful maternity care, and we can still see the keywords coming through. This mother should be free from harm and mistreatment. There should be privacy and confidentiality. There should be dignified care, information giving, informed consent, support and companionship. The environment and resources should be of high quality. And this care should also be equitable. There should be effective communication happening. The mother and the partner should have the choice to make decisions for themselves, and they should also be cared for by competent and motivated human resources. And also the continuous care is very important in this regard. So I tried to relate the respectful maternity care and looking at the WHO intrapartum model of care from the guidelines. And we see that this model of care is basically respectful maternity care in totality, because all the components of that a mother is expected to get, the type of care she's supposed to get in intrapartum care, really encompasses what respectful maternity care is all about. So somehow it becomes a very big thing, and it can sometimes be very hard to measure, especially when you do research. And I think Drelis touched on this. What is the effectiveness of the interventions? So that's where the challenge can come from, that with all these components, so how do we measure that we are actually providing respectful maternity care in totality? So yeah, so these are some of the ways in which abuse has been reported in literature, and this is research from, you know, from different studies, and I'll just talk about the themes that have come out, things like physical abuse, sexual abuse, verbal abuse, stigma and discrimination, issues with health system conditions and constraints, which also really encompass the respectful maternity care spectrum, failure to meet professional standards of care, and poor rapport between women and providers. So these are things that, you know, came out as they did a review of literature on disrespectful care. And there's really so much into this. But I'm not dwelling on that. So I want to just talk briefly about the challenges that come up when we say we are implementing respectful maternity care. Because of the so many components of respectful maternity care, you're looking at, okay, what are we really doing? What are we implementing? So there are issues to do with the environment, and within the low resource settings, things like companionship become a big challenge, providing privacy and confidentiality. So from our study sites for the ALERT project, most of the facilities do not have separate rooms for mothers who are in labor. And so privacy becomes an issue, confidentiality becomes an issue, because as you take history, you know, there's no private space that, you know, the mother can freely share her information that other people are not able to hear. Then we look at hygiene and issues of dignity, personal dignity. Where is this mother, you know, being admitted? Where, which toilet is she going to? How is she able to get food while admitted? And this also cuts across to the health workers. The environment that they are working in can be a big challenge. And then safety in that, you know, in regards to the physical environment, the physical infrastructure. Is it safe? Is the baby safe? Is this mother safe while she's admitted? Then when we go to the issue of competent and motivated staff, we look at issues to do with manipulation and control, whereby the health workers want to be able to do their work as quickly as possible. The respect and freedom from harm also comes with the competence of the health worker and their motivation, their ability to really respect these mothers. We have also the ability for the health workers to allow the mother to make choices and opportunities to make decisions for themselves. And also, under the competent and motivated staff, we see that another challenge becomes the organization of work, the way that health workers are working in shifts, how long the shifts are, who is available at night and who is not, who is available at the different levels of facilities. As we know, in the low resource settings, that sometimes, you know, during the weekends, there are so many challenges, and you find that women are not really getting respectful care. And then when we go to resources, I think this is sometimes becomes really too monotonous, too much to keep talking about lack of resources. So this leads to poor monitoring, and that means that you cannot make really the right decisions for this mother. The poor referral systems make it hard to achieve quality of care, and also the respectful care in that sense. And then also it's impossible or difficult to make timely interventions, and therefore there's lack of equitable care, because now it's the people who can be able to maybe get a driver or pay for a car or buy fuel for the ambulance that will end up reaching in time at the facility. And so, you know, the resources also become a very big challenge to implementing respectful care. Then we have this component of knowledge and information, where sometimes it's the issue of lack of knowledge on the health provider's side. And so they lack skills to, for example, offer pain management in labor. They lack skills of different birthing positions, so they cannot offer that, poor communication skills, and there could be some lack of negotiation and problem solving skills, especially when there are challenges, and this can lead to stress and disrespectful care, verbal abuse, and different things happening with the clients. And so these are some of the issues that we found out in our baseline study as we explored the environment in the setting that we are implementing the alerts project, what is actually happening when it comes to being able to offer respectful maternity care. So I wanted to also, highlight a few opportunities. This list might not be exhaustive. Sometimes it's really hard to say where are the opportunities and what do we have available. But in our setting, we have administrative support and the will to improve the quality of care. We have skilled healthcare providers. And actually, in our assessment of the knowledge and skills, we found that health workers were really high on most of the essential knowledge and skills for providing maternity care. And then, of course, there's some infrastructure that could probably be remodeled or, redesigned to be able to provide this respectful care. And then the provider's willingness to change is another issue that is variable, but not everyone really loves the situation as it is. And then partnerships and donor support is also available in many of the settings. And so I just want to talk about the ALERT intervention and what we are doing so far. So ALERT stands for Action Leveraging Evidence to Reduce Perinatal Mortality and Morbidity in Sub-Saharan Africa. And it is a quality improvement and implementation science project that is in 4 countries, Benin, Malawi, Tanzania, and Uganda. And the overall lead is Prof. Claudia Hansson, who is based at Karolinska Institute in Sweden. And the Ugandan lead is Prof. Peter Waiswa, who is, I think, also, part of this implementation science project. So the goal of the project is to develop and evaluate a multifaceted intervention. And one of the aims is to strengthen the implementation of evidence-based interventions and responsive care, and also to reduce in-facility perinatal mortality and morbidity through a multidisciplinary approach. Our study protocol is already published, so you can actually go and look it up so that you can read a bit more of what we are doing. And so this is our conceptual framework. And we start with the end user participation, where we did the co-design of relevant and respectful patient-centered care. So we did some interviews with all the stakeholders, the health workers, the mothers, the partners, and other key informants, and we got to know what is happening and what is lacking in terms of respectful care, responsive care, and patient-centered care. And from this baseline analysis, we also actually looked at the skills of the health providers, especially the midwifery health providers. And with this knowledge, we went ahead to design a training package, a competency-based training package based on the gaps in midwifery competencies and the challenges that were brought out by patients regarding respectful care. So we used this package to train the midwifery providers on the different aspects where they felt there were gaps. And so after the training, so then we continue with the mentorship for empowerment and leadership. And we also do coordination and accountability with the administration. And we are also doing quality improvement approaches, looking at really, again, the gaps that we found in the end user participation. So this is how the alert intervention has been put together. And yes, like Drelis said, it's also really not a single intervention. So it's a multi-component intervention, which is really, which we believe can go towards achieving good intrapartum care and respectful care in total. So this is what we expect to come out of the different components. We are looking at some of the outcomes to be responsive care, and we are really assessing this using a questionnaire that we give to our mothers who leave the facility. We are also looking at client-centeredness as one of the impacts that we shall achieve, but we also hope that the intrapartum care will generally improve. So things like time from decision of to perform a Caesar to delivery of the baby will improve. We believe that intrapartum related mortality will also reduce. So what we've done per se is to really harness the opportunities. So we've developed a mentorship cascade, and this cascade starts from the alert team, the members of the team who are really so much into clinical practice, the midwifery providers mentoring the people at the clinical sites, and the leaders at the clinical sites also mentoring the midwives that are providing care. So we have that cascade that is ongoing in the intervention facility for now. We are also doing leadership coaching at also different levels, and supporting the midwifery leaders to advocate and to be able to speak, supporting them to have a voice regarding components of the respectful maternity care issues. And then we are also doing continuous assessment of learning needs and interventions. So we continue to assess the learning needs of the health workers and provide refresher trainings. And also the quality improvement initiatives are ongoing, and we are collecting data using a perinatal e-registry where we take different parameters and looking out for that. We are also assessing, as I've said, responsiveness and respectful care, and looking at that every 6 months. We've also, try to engage the administration and the facilities and offer support as much as possible within our network. And also we are doing collaboration, coordination and advocacy at different district levels, at the Ministry of Health levels, and at the global level, because this is a global project. And so when it comes to staff motivation and change of attitudes, I just put a question mark that we hope to achieve that through our mentorship, through our leadership coaching, through our engagements. But there are a few other things that can be done, and we hope these will come out of the quality improvement projects as ideas from the users themselves, the providers themselves, on what is possible, what can motivate them in terms of changing attitudes. So things like recognition of healthcare providers with awards, changing of the working environment, positive role modeling and champions, which is something we've started on, and training in self-awareness and bias consciousness would be things that could improve, the staff motivation and changing attitudes to providing respectful maternity care. And so that is what we are doing so far. Thank you so much. And I think I will get questions later on, but I want to acknowledge our funders, Makerere University and the ALERT team for the work that is going on. Thank you so much.
Thank you, Elizabeth, for that presentation. Yes, questions will be answered at the end of these presentations. So we need to give patient-centered maternity care, which is respectful and responsive to individual women's preferences. And we also need to improve our communication to our clients. Yeah, as we've heard, we should not use force, harsh language, and threats as we take care of our women. Yes, I can see Dr. Kamanga, are you ready to give your presentation? Dr. Kamanga? Dr. Karingo? Dr.
Yes,
Karingo?
Yes, Rahel.
Is Dr. Martha with us? Or we move on?
I can see she's with us, but we are not able to hear her. She's on mute.
Yeah.
I think we can move on to the next discussion and she'll let us know once she's ready.
Oh, okay. That is fine.
Yes, Rahel, we are not able to hear you. Hello. Hello, Rahel. We can see you're on unmute, but you're not able to hear you. Apologies, I thought it was from our end. Maybe can you use the other account? Rahel Mukwana?
Yes.
Yes, we were not able to hear you.
Oh, what happened?
I'm not very sure, but maybe you can introduce the next speaker and we can go ahead.
Okay, I'm so sorry. I thought you could hear me. Yeah, we want to welcome Dr. Beatrice Amuge. Is she with us? Yes, I can see she's online. Dr. Amuge is the Commissioner Health Services at the Ministry of Health in Uganda. Previously, she has served as Assistant Commissioner Health Services in Mulago National Referral Hospital and Jinja Regional Referral Hospital. She served as a part-time lecturer in Makerere University College of Health Sciences, Department of Nursing, acting principal in Public Health Nursing College, and clinical instructor in Mulago Nursing and Midwifery Training School. She holds a postgraduate diploma in management from Uganda Management Institute, a certificate in health services management from Makerere University, a master's in public health from Makerere University, a bachelor of science in nursing from Makerere University. She's also a holder of diploma in public health nursing from Kiambogo Public Health Nursing College. And she also is a registered nurse midwife, from Mulago Nursing and Midwifery Training School. She'll give her remarks on respectful maternal care and also some remarks on the presentations that we've just had. Welcome, Dr. Beatrice Amuge.
Thank you so much. Thank you for the introduction. As a way of remarks, I have a short presentation, but mainly remarks of respectful maternal care in Uganda, briefly, and then I will hand over. Can you all see that screen? Can you see the screen?
Not yet, not yet.
I'm not sharing.
Not yet.
Oh my God. Is it there now?
Yes, now it's there.
Yes, it's there.
Oh, okay. So I am just going to say briefly what how we handle respectful maternal care in Uganda. And like I was introduced, I'm Beatrice Amuge, Commissioner Health Services, Nursing and Midwifery in the Ministry of Health. And for us in Uganda, that's the lead nurse in the country. And I'm a public health specialist. In Uganda, we are mandated as nurses and midwives to observe ethical code of conduct at all times while delivering care. And the key ethical code of conduct emphasized includes, but not limited to, the number of them. There are about 20 codes of conduct we follow as nurses and midwives in this country. Of course, we are supposed to be smart, presentable, and well-organized. And this actually tallies with respectful maternity care, that you should be able to welcome the mother and make sure that you are smart to win the rapport with the mother. One of the ethical code of conduct we observe in Uganda is integrity, to be empathetic to mothers, have exceptional interpersonal skills. I say exceptional so that it is professional interpersonal skills, confidentiality, effective communication skills, effective such a way that when you are communicating to mothers, there should be a feedback. Then maintain privacy, self-regulation, and be initiative. Uganda being a low resource setting country, you find that we try to make a lot of initiatives in order to deliver our care, and specifically the respective maternity care as a country. Now, respective maternal care actually emphasizes the applicability of this ethical code of conduct in delivery of maternity care. And it, as a country, we think it categorizes the other ethical code of conduct of healthcare providers in three main principles or three main domains, which has already been discussed. That is equity, dignity, quality. And we need to know that all women deserve respectful maternity care as a right. And in Uganda, we know and we do practice that all mothers should have respectful maternity care as a right, not a privilege. When you look at equity, there should be access to service. In access to service, we make sure that these mothers have a professional service as a right, irrespective of the status. They should be attended by professional people or professional midwives so that they get the right service. Inequity, we look at discrimination. There should be no discrimination irrespective of the race. For example, Uganda gets even people outside the country, we get refugees, but when they come here, we make sure that they enjoy the services which the local people in the country are enjoying. There should be no discrimination according to maybe disability they have. However, we have at times limited infrastructure that allows some of this care to be given to the disabled mothers. But I'm happy to inform members that now the buildings, the beds for the disabled mothers have been put in place. And this is one of the things we want to make sure that all the mothers get equitable access to services. Respect. Mothers should get the services with respect. Their views should be respected. The way they are handled should be respected. And they should also get attention, medical attention, which they deserve. Like I said, respectful maternity care should be a right to all women, and they should be respected. On dignity as a country, we make sure that mothers get tender, loving care. The midwives are emphasized to make sure that they get that rapport with the mothers. They take care of them. They make them feel at home when they are having this care. So they have to be so close to the mothers. They have to understand their problems and support them when it comes to respectful maternity care. Privacy. The privacy should be observed, that mothers should be in a place which supports them or observes their privacy. And there should be confidentiality. Privacy will refer to maybe environment where the mothers will be, and then confidentiality is on information. The information received from the mothers should be for the mothers. And this is what we emphasize in Uganda, that the information the mother gives you should be for only you. For you to disclose this information to another person should be with the consent of the mother. We also look at listening with compassion. We have to listen to our mothers. We have to give them health education. Health education is given either as a group or as individuals. And after that, you try to listen to them, understand what the mother is saying, and let the mother understand what you are saying. It is actually a two-way process. The mother should be allowed to make informed decision, either alone or as a group. We have also opened it up that mothers can be accompanied to the health facility. either by other fellow women, by other relatives, or by their husbands. So there should be decision making. Mothers should be given the information and they make informed decision. In Uganda, we also have what is called a client's charter or patient's charter, which emphasizes that the mother or patients have a right to choose what they want. They have a right to choose the care. They have a right to choose the health worker to give them the care. They have a right to choose where they get the care from. We emphasize on equality, and equality is to make sure that the mother and the baby are not harmed. We reduce the maternal and mortality and morbidity rate. We also reduce the stillbirth, and all women and babies should not be harmed. And we emphasize kangaroo mother care. This one supports in reducing the stillbirth in Uganda, and it is practice. We also, like I said, that encourage the relatives to be there to support the mother while giving birth. And we also encourage the husbands. The challenge we have is at times the infrastructure may not allow them in the labor ward, but of course we have the policy, but because of the infrastructure, they may not be allowed in labor ward because we look at privacy, and since they are a bit small, but outside labor ward, they are allowed to be with their wives so that they support them, improve the quality of the care given to the mothers. Well-trained health workers. In Uganda, we train the nurses and midwives, and now we have a harmonized training in the level of a diploma, the level of a certificate, such a way that they have the same knowledge and skills. And we ensure that mothers get a good care in order to reduce the mortality and morbidity for both the mothers and the babies. So the training is there for health workers and is now harmonized training. And we make sure that we use the right gadgets when we are giving our maternity care for quality. Exceptional relationship, like I said, there should be exceptional relationship between the health workers and the mothers. This one encourages more mothers to come to the facility. It encourages them to use the services. It also causes that rapport and makes our mothers to open up, free to communicate with the health workers in the facility. The care given to the mothers in the facility to be quality. We look at the nutrition. If the mother is feeding, of course, at times we may not give them food 100%, but at least we guide the relatives on what to bring in terms of nutrition. And then we also look at the medication, which in most cases get from health facility, psychological support, and then appropriate observations, interventions, referral, and also we emphasize on reduction of the 3 delays in looking at respective maternal care. Delay, there are many factors which cause delay at home. We try to look at that and see how best it can be supported. Delay at home includes the decisions made of who should take a decision for the mother to get a health facility service, maybe a decision to get the money for transport, cultures, all those any delay at home. The second delay is on transport, the way to hospital, the transport they use, the roads, the money maybe for transport is also another delay. And then the other delay is within the health facility. As Uganda, we have looked at all those delays and we try to see how best those delays are handled. The other one is exceptional relationship, like I have said, that the health workers try their best because they have been taken through the ethical code of conduct, which I had said at the beginning, and they are supposed to make sure that the relationship between them and mothers is exceptional and encourages them to use the facilities. Impact of respectful maternity care in Uganda. Because of what I have already emphasized, you find that there's increase of skilled birth care utilization. Mothers, when you go to the health facilities in Uganda, you find that they are overloaded. Actually, it is the service which receives more patients, more mothers than any other service in the health facilities. It's because of the respectful maternity care which has been put in place. There are now increased deliveries because of the addressing those the 3 delays, and also the ethical code of conduct which has been emphasized, plus the client's charter or patient's charter, which has been disseminated widely, and the population knows their rights and responsibilities. It has actually caused increase in facilitated deliveries. More mothers now come for delivery. Of course, I am aware that during COVID-19, some of these services were affected, but still maternity services were more handled than any other service in the country. There is reduced maternal morbidity and mortality, and there is also reduced stillbirths in the country. However, there is also reduced infant morbidity and mortality. Client satisfaction. We have a mechanism of getting some of these comments from clients as a country. We have suggestion boxes. We get information direct from clients, and they express their satisfaction in the way the services are being conducted. And then, of course, this will go a long way to have a healthy population. And as you are all aware, a healthy population is actually a highly productive population. However, among all these very good things I have said, like any other country, I'm sure, we still have shortfall in staffing, which I'm sure is experienced by many countries worldwide, that at times we get a challenge in staffing. And also there are now the new birthing positions, which are still new in the country, but there's a lot of mentoring, there's a lot of support supervision going in as a country, and we believe all this information is going to be disseminated, and then the practice will be done well. I want to thank you for listening. I do appreciate you. Now on my comment on the previous presentations, I think they are all properly presented, and most of the things which were mentioned cut across in most countries in Africa, even the challenges, even when you look at the other non-respectful ways for mothers, like abuse, you know, some of those things I think cut across, and we need really to appreciate. And then we also need to see how best can we handle it so that we eliminate some of these things and we have a respectful maternity care or maternity services in our countries. I thank you for listening. Over to you. Thank you.
Thank you very much, Commissioner, for your remarks. And I do agree with you. We need to only share information when consent is given by the mothers. I think during our ward rounds, the way we do our ward rounds, especially, okay, let me talk about my hospital in KNH. We have so many patients in the ward, and you're teaching, there's teaching going on, and you're discussing about the patient, and yet these patients are sharing beds. So we need to really look at our infrastructure and see how we can improve it so that we can maintain confidentiality. Now we'll get remarks from Dr. Kireki. I can see him online. Dr. Kireki is a consultant obstetrician gynecologist from University of Nairobi in Kenya. He is also a fertility expert, and currently he's the president of Kenya Obstetrics and Gynecology Society of Kenya. A lecturer at the University of Nairobi, a senior lecturer at the University of Nairobi. Welcome, Dr. Kireki, to give your remarks.
Thank you. Thank you, Raheli. Thank you, everybody who has given their presentations, right from Professor Drelis, Elizabeth, Aya Bere, and everybody else, Commissioner Beatrice Amube. I'm delighted, I'm very, very delighted to be here. I've sat here and I've been listening to the contributions that, that we have made. And something just crossed my mind. I'll take you back a little bit to a gentleman who actually lived in medieval times, and his name was Moses Maimonides, or Moses ben Maimonides. And he gave an oath, and I'll quote a bit about the oath, then I'll talk a little bit about what has been presented, and I'll wrap it up with one or two questions. And the oath of Maimonides goes this way: the eternal providence has appointed me to watch over the life and health of thy creatures. May the love of my art actuate me at all times. May neither avarice, nor miserliness, nor thirst for glory, or for a great reputation engage my mind. For the enemies of truth and philanthropy could easily deceive me and make me forgetful of my lofty aim of doing good to thy children. May I never see in the patient anything but a fellow creature in pain. Grant me the strength, time, and opportunity always to correct what I have acquired, always to extend its domain, for knowledge is immense, and the spirit of man can extend indefinitely to enrich itself daily with new requirements. Today, he can discover his errors of yesterday, and tomorrow, he can obtain a new light on what he thinks himself sure of today. O God, thou hast appointed me to watch over the life and death of thy creatures. Here am I, ready for my vocation, and now I turn unto my calling. Respectful maternity care, which is basically patient-centered. That is a topic that has had a lot of traction in the last decade or so. A lot of work has gone on, and I'm proud to say that most of this work is actually, or what we're talking about is basically in our space, meaning in Kenya, Uganda, Tanzania, Malawi, and so on, which is very, very, very good. Now, we know that if we are going to respect our patients, if we are going to treat them with respect during their antenatal care and their maternal, during maternity and delivery, we know that respectful maternity care is going to have a huge impact. Number one, these patients are going to be happy, and they're going to be satisfied. There is nothing that satisfies us as healthcare workers, especially those ones working in maternity and labor ward, when we have a safe delivery. When a mother goes home, who is happy? The mother is happy, the baby is also healthy. It's one of the best things that that comes out of our work. But sometimes things do happen that this doesn't happen. Number two, respectful maternity care will also reduce maternal mortality rates, because these patients are going to be happy. They will talk about going to this and that hospital because the staff there are welcoming, they are warm, they are empathic, and they do care about the well-being of their patients. Number 3, it will reduce stillbirths. It will increase a healthy population. I think these points have been pointed out by our by Commissioner. It is a well-known fact that WHO actually recognizes this as a principle. This principle of respectful maternity care as a major factor for the increased use of pregnancy and maternity healthcare services. In Kenya now, we know that the government, as a policy, it wants to have all or most of the patients to deliver in hospitals. Now, when all these patients come to hospital, there are some certain things which have been pointed out, which are very, very important. When the government came up with this policy that everybody has to deliver or should deliver in hospital, things came out. And these are things which are interconnected with the care that we give, the respectful care that we give. Number 1, there's an issue of dignity, there's an issue of privacy, issue of confidentiality, etc., etc. When you talk about privacy and dignity, when you have, 4 patients to a bed, 2 patients to a bed, sometimes even 4 patients to a bed, is that really respectful maternity care that we're giving? That is one of the questions that we need to ask ourselves. When you talk about confidentiality, because Mukwana here mentioned about the hospital we work in, Kenyatta National Hospital, sometimes it's difficult to actually sort of abide by this confidentiality, because when you tell a patient this is what is happening to you, this is supposed to be confidential information. The other patients who are in the same room will actually have access to this information, not because they want to, but by virtue of the conditions that they have found themselves in. Sometimes when these patients are delivering, there's one patient delivering here, another one delivering there in different phases of stages of delivery. This one has delivered. When we deliver these patients, when we are actually doing a check to see whether everything is okay, do we really give these patients the privacy and the dignity that, that they need? Do we cover them? Do we have a screen such that the patient in the next bed, or are the doors closed to them, to the ward where they are doing the delivery? Can somebody just walk in? Do we even knock on the door when we are going into into a ward? Some of the questions which we need to deliberate upon and think about. Effective communication, something without which it's very difficult to deliver a good quality service. The ability to empathize with this patient. Sometimes these patients are, delivering for the first time, and they may not have any idea about what they are going to go through. How do we empathize with them? How do we deliver the information to them? How do we sort of tell them it will be okay? And how do we do this when we have 20, 30, maybe 40 patients on the floor? All have come with different issues. We have the ratio of the midwives to the patient is very high. The ratio of the consultant to the patient is also very high, very low. Sorry for that matter. You have one consultant to to all the patients who are available. Do we have enough staffing? Do we have enough medical officers? Do we have enough nurses, midwives? Sometimes we forget the support staff as well, because if we don't have a good support staff, then the porter to take the patient for a scan, the porter to take the consultancy request, etc., to them, different departments, and to the lab, etc. This will hamper the delivery of our services. Talked about equity, talked about dignity, talked about quality. When we talk about equity, we need to look at it in different ways. We need to look at the access to this service. We need to look at the availability of this service. We need to look at the affordability of this service. It is said, the government of Kenya wants everybody to have good quality service, but we don't take a step back. I tend to think that most governments, that's what they do. They decide this is what we're doing without taking a step back and calling the people who are actually on the ground and asking, if we do this, how will it affect your delivery of services? Do you have enough people? Do you have enough room? How will you have the equipment? How will you have the medications, etc., etc. Sometimes it's disheartening when I go for a ward round in labor ward and I'm told this medication is not available, this medication is not available, this patient, has preeclampsia or has this, and we don't have that medication. Sometimes you go to theater and, a patient is having PPH and we don't have this medication or we don't have that medication. Is this quality education, quality and respectful maternity care that we're giving? This is something that which we need to look at. When you talk about dignity, I think I've talked about privacy and confidentiality. All these things are sort of tied around human resource and resources themselves, the capital that we have to invest into delivering respectful maternity care. Talk about again about lack of equitable care. Is the care that we give in the hospitals in the cities the same as the care that our mothers get outside the cities, in the county hospitals, in the far-flung county hospitals, in the sub-county hospitals, or even in what we call level 4 hospitals? It is not the same. In as much as we want this care to be equitable, it may not be the same. Why? Because again, we come back to the weakest link, which in my opinion is what still hampers us from giving respectful maternity care. Human resource, and then resource the money that we are going to invest in the healthcare system, such that we can be able to train people, such that our mothers can be able to access these services, such that we can be able to reduce the three delays, and so on and so forth. Untimely interventions. In our hospital, with Juana, sometimes in the past, you do a ward round, a labor ward round, maternity ward round, you find you have 10, sometimes 15 emergency C-sections waiting. You find this one has come with a previous CAM, this one has 2 previous CAM in latent phase of labor, this one has antenatal hemorrhage, this one has preeclampsia. It's all a mix. Sometimes it is so difficult to prioritize and say, you go first, you go second, you go third. Sometimes these emergencies take long to take care of. And the outcomes sometimes are not good. So we need to sit, we need to talk, we need to lift our voices, which is what this forum is doing today. And I want to thank you for inviting me, because from where I sit as the COGS president, we see quite a lot of these things and we need to talk about them. And it's by talking about them that we do get solutions. So the last thing I want to ask, is all lost? No, it is not all lost. Just like Maimonides said in his author prayer, what we thought we knew, we may find that today that knowledge is outdated. People never used to think about respectful maternity care, but now it is a huge cog in the delivery of services that we are giving to our mothers. And it is time that we have a serious discussion and we engage more often, not just amongst ourselves, because we are learning what ALERT is doing in Uganda. We are learning about what other people are doing elsewhere. We can take these positive things and implement them. But most of all, I'm proud that Commissioner Beatrice is here, which shows them the seriousness of involvement of the Ugandan government. I wish that the other governments also would send, high-ranking officers, such that when they go back to the policy making, they can sit down and say, this is what people on the ground, healthcare workers on the ground, the ones who are delivering our ladies, this is what they are saying. How do we create policies such that they will make the conditions of work better for the workers, and consequently, downstream, the quality of care and the outcomes of the care that these healthcare workers are giving will result in better statistics, better maternal mortality rate, and so on and so forth. So respectful maternity care, it has to be patient-centered. And then lastly, maybe I would just say this from a personal point of view. Do we take care of our patients the way we would take care of our own? And this is something which I'm trying to inculcate in our students. When we do a ward round, when they present a case and I ask, what would you do if it was your wife? Or what would you do if it was your sister? And immediately I ask this question, things change because they say, my wife, I will do slightly different. I will do this or something completely different from what they have suggested. I say, look, you cannot have two different decision-making, mechanisms. You have to have only one. You have to have a mechanism, a principle, because principles don't change. If I'm going to treat my patient, I'm going to treat the patient as I would treat my wife if she was in such a position. So when we have that approach, then the respectful maternity care actually becomes automatic. Then we won't shout to my wife if she was the one delivering. I will not abuse my sister if she was the one delivering. I will not do this and do that if it was my sister or my cousin or whoever it is. So it comes back to what the old book says, do unto others what you would like them to do unto you. Thank you very much for inviting me, and I hope I haven't taken too long with my comments. Thank you very much.
Thank you very much, Dr. Kireki. You didn't take too long. We wanted to hear some more. I wish we had more time to listen to you. Yes, Dr. Kireki has asked us, do we take care of our patients as we would like our own to be taken care of? That's when respectful maternity care will start. Yes, he's also mentioned about human resource. This we can talk from today, now till tomorrow. We need to increase more midwives in our labor ward. We need to increase more obstetricians in our labor ward. And I don't know how we are going to stop brain drain. For me, it's more of a brain drain. We are exporting a lot of midwives, and doctors are also leaving the country. So we are left with no one to take care of us. Yes, I don't know if our second presenter, Dr. Martha Kamanga, is still with us and would like to give her presentation now.
Yes, I'm here.
So you're able to give the presentation now?
Yes, I can give the presentation.
Okay. So Dr. Martha Kamanga is currently the head of department for the midwifery section, a senior lecturer and researcher for Kamuzu College of Nursing, part of the University of Malawi. She is a registered nurse midwife with the Nurses and Midwives Council of Malawi. She received her PhD in nursing from the University of Illinois, Chicago, and her master's in sexual and reproductive health from the University of London. Dr. Kamanga is very experienced in generating evidence for STI, HIV, adolescents, maternal and neonatal health. She is a co-investigator on the APPHC study titled Implementation Research on a Provider Behavior Change Approach to Overcome Social Normative Drivers that Impact on the Quality of Postpartum Hemorrhage Care in Malawi. She will be presenting her work on the Advancing Postpartum Hemorrhage Care project. Welcome, Dr. Martha.
Thank you. As you've already heard, I first apologize for not being there. I had internet issues, but all the same, I'm here. As you have already heard, my presentation is on promoting respectful maternity care while addressing gaps in quality of PPH care in Malawi, results, successes, and lessons learned. And this was done between our university and the other universities of University of Carolina, San Francisco, Population Council, URC, and supported by USAID. Next slide. So with advancing PPH care, we had our objectives, portfolio objectives, generating and testing solutions, addressing implementation barriers, and advancing effective interventions and strategies to strengthen care. The PPHC portfolio, as you may see in the graphic picture, contributes to the strengthening of systems to improve PPH prevention and treatment through addressing key domains drawn from the Maternal and Child Survival Program PPH framework. And it dwells on several areas like strengthening provider knowledge, skills, and support for PPH, improving referral and safe transport, enhancing essential PPH commodities, increasing use of actionable information, improving policy and governance, and advancing woman-centered respective care. But for Malawi, we had several interventions tested. We had facility mentorship program with Pronto simulations. These were simulations with healthcare providers in one of our districts, Zomba, and we tested in 7 facilities. So these were PPH simulations and also COVID management and COVID PPE simulations and teamwork and communication. On methodology, we had baseline and end-line data collection, and 288 provider interviews were done. 660 client exit interviews were done on baseline, and 305 provider interviews at end-line, and 732 client exit interviews at end-line. Next. So results on Pronto simulation intervention. Our insight was providers lack practice managing life-threatening hemorrhage emergencies, which often serve as triggers for disrespectful care. So our solution we had to do in facility mentor-led simulations and team training, covering primary causes of PPH with additional of COVID identification and PPH. So we had 4 simulation scenarios which embedded live mother actress. As you can see in the picture, there's a live mother actress and the providers assisting the mother actress. And during these simulations, there was teamwork where we incorporated both nurses, midwives, and clinicians and doctors. And there we encouraged communication, we encouraged interprofessional collaboration. And also, as they were doing this, there was promotion of respectful and dignified care. And on the other picture, you can see provider applying uterine massage in a respectful manner. Next. So our results showed that provider PPH knowledge increased in Malawi. PPH knowledge scores in control and intervention district showed a difference. The first graphs are for the one district, Lilongwe, which was the control district, and then Zomba was the intervention district. And if you the green bar is the baseline, while the red bar is the end line. So the mean knowledge scores increased 14% in Zomba intervention district, p-value of 0.001. And for the control district, it decreased 9%, p-value 0.023. And then the difference in differences analysis supports findings. Next. On provider PPH self-efficacy, we found that the provider PPH self-efficacy increased in Malawi, and we compared the scores in control versus intervention district. The first one, blue, is baseline, and then the other color is end line. That's Lilongwe, our control district. And we have Zomba, our intervention district. And there were significant increases in self-efficacy observed in both intervention districts. Significant improvement from baseline to end line in Zomba, the p-value was 0.0015, and there were significantly higher scores in Zomba versus Lilongwe, our control district, at end line, which is 0.0032. And difference in differences maintains increase, showing that in our intervention district, it worked out. There was increased provider PPH self-efficacy. We also had an intervention on birth companions, and our intervention clarified companion laws and produced briefing materials for birth companions. We collaborated with stakeholders to understand how companions provide valuable assistance to providers or commonly interfere with care provision. We produced materials to help providers brief companions on their laws. And this was tested in Dowa and Baraka districts with the 105 participants, and 76% saw the poster and or brochure. 64% used the materials to brief companions. As we can see from our qualitative data, the birth companion materials are straightforward, very reliable, that it is easy to tell others what they are saying, so they are very helpful. That was a narration from one of our participants. So monitoring data indicates that providers briefed a companion for nearly all women at 97% who delivered during the test period. Next. In our intervention districts, Dowa and Baraka, there was a significant increase in birth companion during labor and delivery. As we see the graphs, like the dark blue is labor at baseline, the light blue labor at end line, and then the dark green is delivery baseline, and the green is delivery end line. So more clients in study district Dowa and Baraka reported birth companion attending at end line compared to baseline. Labor, like almost 23%, p-value was significant, similarly at delivery. Also, clients in comparison site, Lilongwe did not indicate significant change in birth companion, as we can see from the graphs. We see that companion attendance increased during both labor and delivery from 29% to 50% in study sites, p-value of 0.001. And then companion admission through labor and delivery decreased from 47% to 37% in control sites, likely due to COVID-19 practices despite MOH guidelines. So I think COVID-19 affected the control district because we couldn't allow the birth companions to be in the labor ward to decongest the labor ward. Next slide. Also, we had a question on to hear client perspectives on respective maternity care, and the PCMC subscale was used on selected item scores, and this personal-centered maternity care subscale had several categories, including communication and autonomy subscale. The first category, where we wanted to know about where providers called them by their names. They wanted to know if providers called the patients by their names. Also, there was an element of dignity and respect subscale, where we wanted to know if information was kept confidential, and supportive care subscale, where there were things like water, electricity, utilities. And on this one, of note, reports of physical abuse were low. Communication, autonomy, and support scored lowest. And we found that these could be opportunities to reinforce the intervention. Next slide. Also, we wanted to hear about respectful maternity care from the provider's perspectives. And we see this crowded slide. I know you cannot see what is there, but what this slide is trying to do is to ask maybe some elements of respectful maternity care. For example, how often do providers introduce themselves to women, refer to a woman by name, cover a woman with a cloth or screen, and or explain to a woman why they are doing an examination on a woman procedure or test. So there were several elements on that slide. But then on results, what this slide is saying, when you ask providers about their own respectful care, the areas with the greatest room for improvement are introducing themselves, providing a birth companion, offering position of choice, and provision of pain management. We found that this is an opportunity that we can strengthen these elements to promote respectful maternity care. Next. So another area where we intervened was on supporting provider mental health and well-being. Next. We had questions on this one, on do mental health factors influence respectful maternity care? Or what protective factors might relieve stress and where might interventions be applied? Next slide. So on this one, we examined how providers experience symptoms of burnout. And the graph shows some areas, like if the provider feel like they are working too hard, they are fatigued when thinking about work, they are emotionally drained, they are used up or out of patience, they are burned out from work or blamed for their patients' problems. So our results showed that nearly half said they felt they were working too hard, 2 or more times per week. And roughly a quarter reported feeling emotionally drained, out of patience, or burned out from their work, or that they felt tired when they thought about going to work at least twice per week, which support the idea that providers really experience burnout symptoms. Next. And also we found that high emotional exhaustion and depersonalization was linked to reduced respectful maternity care. On this one, we found that providers with high emotional exhaustion or depersonalization, like 101 participants, reported lower overall PCMC scores. These providers were also less likely to always assess pain or explain a procedure to their clients, or never verbally or physically abuse a patient. So the graph just explains that you can see the different parts of the graph where, like the first 2 bars explain assess patient's pain, burnout or no burnout. And then the other one explained reasons for procedure, burnout or no burnout, like burnout 38% to no burnout 58%. And physically abused a patient, 88% burnout, 98% no burnout. Verbally abused a patient, 63% show burnout, and then 78% no burnout. Next. That is a narration from one of our IDI participants. Said some providers will keep on hating psychologically after an incident at work. For example, PPH. If they experience PPH, they'll be so stressed that they can't perform their duties well. So this narration tells us that supporting provider mental health and well-being is essential to provision of respectful maternity care. We had a lot of narrations on this burnout, but this was just an example of how the providers felt. So lessons learned from all this. We see that findings provide insight into future intervention design and considerations for respectful maternity care. Exhaustion and depression directly reduces person-centered maternity care scores. Supportive relationships with facility management can protect against burnout and improve respectful maternity care. We also learned that training focused on knowledge and skills are opportunities to reinforce respectful maternity care behaviors and support provider well-being. And facility action plans for PPH, caring for the carers, values for clarification are a key in supporting healthcare providers. I think our interventions that we did really helped the providers to lessen their stress levels, but we hope to do more because this was only done on intervention districts, but then we still have remained with the control district. For future planning, we might target the control district because there is a difference between the control and the intervention district, both at baseline as well as end line. Thank you.
Thank you very much, Dr. Kamanga,
Yeah,
for your presentation.
Mm-hmm.
Yes, I know if we, PPH really kills many women in our labor wards. And if we need to reduce or we need to manage PPH, we'll have to train more midwives who are always there in the labor ward and also improve their skills through simulations. They need to know how to manage the PPH, which I believe most facilities are doing. Yes, and again, after an event, having worked in labor ward for more than 20 years, after a PPH event, it's really exhausting for the healthcare provider. So we need to give psychological support and maybe debriefing after an event. So thank you very much. Dr. Karingo, I don't know if we have any questions. I'm not able to view the questions from my gadget. There must be something wrong with my gadget. So do we have any question? At this juncture, yes, I want to also welcome the panelists. Yes, I want to ask the panelists or the speakers to join in the question and answer session. But I will ask Dr. Karigo to do that for me.
Yes, we had quite a very few questions, and I can see some of them had been answered. But maybe from what I can see just directly on my screen, yeah, we have a comment from Afwandi saying, really true normal delivery should be left to midwives. I hope this respectful maternal care should be adopted across all facilities. And we have quite a number, yeah, that's very important. And we have quite a number of comments from the chat box where people are very grateful for this session. And just commending the wonderful presentations that have been going on and asking even for the scale up of the same. So we are really happy that for our participants to be for joining us and for giving those comments. Maybe one question that is lingering here is in regard to confidentiality. In case the mother is HIV positive and she does not want the husband to know, how do you go about this case?
We'll ask one of our panelists to answer that.
Yes, you can give it to Amuge. I'm saying it's been directed to Amuge.
Dr. Abuge?
Oh, thank you so much. Can you hear me?
Yes, we can.
Yes, yes, you can.
Yes. Confidentiality, we have discussed about confidentiality is a person's right. It is a right for the patient, is the right for the mother, that the information can only be disclosed with her permission. So in HIV, there should be proper counseling. If you give proper information, if you give an informed decision, and the mother has understood, the communication we have talked about is effective communication, where you have listened to this mother carefully, and she has listened to you, and you have got a very good, effective communication with good counseling. This mother is likely to agree that the husband should get the information. So once a client or a mother has declined, the information should be disclosed without her permission, you have no right to do that. But if we have not got such cases, you need to do counseling. Counseling is the way to go and is the best to do before you disclose this information. It is a patient right to not to allow anybody to get access to the information. Thank you.
Thanks so much for that response.
Yeah. Any other question, Dr.?
No, I can see most of the questions had already been answered. Maybe just for the benefit of the other participants to hear some of the views, I'd request Elizabeth Aya Bere, if you can just give some of your comments highlighting some of the responses that you gave.
Okay, thank you so much. I tried to answer some of these questions. So the first one was from Anna Alice. And I don't know if it's he or she was asking, what are the current recommended referral pathway in maternal child health, stroke family planning? And I had responded, you can always click and check on the response, but I was not very sure in which sense this question was asked. So I just showed the different levels of healthcare, and the referral pathway ideally should follow from the lowest level of maternity care, which in Uganda is the Health Center 3, where there is a diploma midwife in charge of the maternity, and then go upwards until the referral hospital. However, sometimes even a midwife at Health Center 3, if she deems or he deems that the problem might not be handled at the next level, which is the Health Center 4, might refer directly to the referral hospital, depending on the condition of the mother. So the referral pathway somehow gets a little bit disorganized depending on the need and the services available at the next level of what? Of referral. And this is also one of the challenges that we are having now with too many mothers at the referral facilities and them getting overwhelmed because some facilities are not properly, they are not very well provided at the lower levels where the nearest referral facility is. And then I'll go to Jingo Stephen's question. He says, you seem to concentrate more on midwives. What about the medical officers? I also want to know whether the project is in public or private hospitals. And yes, the ALERT project actually focuses on all maternity care providers. However, as one of the areas that we see is very necessary was to position midwifery or position midwives in their role as the, can I say, the biggest providers of maternity care at all levels of facilities. So the focus was to support midwives to be able to perform the necessary normal midwifery care so that, you know, they can prevent occurrence of complications, they can be able to assess and escalate issues when they happen. And as we know that most women who come to our facilities are able to give birth normally, or if I may say vaginally, and a few will need cesarean section. So in ALERT, our thinking is that if we position midwifery, then we can really reduce the risks, and we can reduce, you know, the expenditure that goes into managing emergencies. Yeah, so that is it. And that our project is in 4 hospitals. We have a private not-for-profit hospital, and we have 3 public hospitals. However, this project, I didn't tell you, it's an implementation project, and it's in a step-wedged kind of design. And so we are starting with 1 hospital, as the other hospitals are currently acting as control hospitals. Then after that, we shall, you know, keep implementing in the subsequent hospitals. Every 6 months, we go to a new hospital. So that is what is happening. And then from Hilary Awar, he says, what's the ratio of midwives to patients at points of care in centers where there's severe shortage of nurse midwives? Is there a role of nurse assistants or attendants in labor ward or theater where ethical issues in management of clients is adhered? So Hilary, thank you for this question. And I just gave you the numbers in our first intervention hospital, that in this hospital we have 14 midwives, 1 doctor and a consultant, and they have around 15 to 20 births per day. And so sometimes it's not, you know, it's not easy to have so many people enough on the shift, because a shift has around 2 midwives. And this facility also has, they have to take care of the antenatal sick mothers. They have also to go to theater to take mothers there. They have to take care of the postnatal, post-operative mothers. So sometimes you find that the nursing assistant is performing some role, but this is outside their mandate. They are really not supposed to perform maternity, you know, they are not supposed to perform, they are not supposed to conduct births, for example. It's outside their mandate, but sometimes you find they are the only people supporting, they're the only ones maybe available to admit a mother, and that can happen in times of severe shortage. And I just commented that severe shortage makes it really difficult to implement respectful maternity care. And this is one of the things that I am making a call to action to the people now in the ministry, to the people involved with recruitment, to see what is really possible. Like, how much can our midwives actually deliver? How much can the one doctor on a referral hospital deliver? How many mothers can he assist with a cesarean birth? And he's the only person available. So we need to also, as maybe government, also think about how much work are we giving the health workers, and we still expect them to provide respectful care. Yeah, that is a little bit of a challenge. And then, yeah, someone else said in some health practices, midwives are only allowed to monitor patients in latent and active labor till 2nd stage. and then they should call the gynecologist just to perform the act of delivery thereafter. The gyne charges his or her fee. It is really intimidating to midwives and more so to the patient who pays dearly. So I don't know, I think this was a comment, and I don't know whether it was to my submissions or to the commissioner's submissions. I'm not really sure. But I responded and said continuity of care is a very important component of respectful maternity care. So it's very hard, you know, on the patients to see this person, the gynecologist or the consultant, the first time when they are just pushing. So if the midwife has built rapport and has monitored, given information, got to understand the mother, this would be the right person to actually also perform the, you know, assist the birth. So this is also something that, you know, creates a lot of power relations. It creates that uneven environment between the different healthcare providers, and it can also make it difficult to consult and to also work together. So it's not good for multidisciplinary working. I think that is it. And then I see another comment here. Thank you, Elizabeth, for this feedback. Very true. Normal deliveries should be left to midwives. Hope this respectful maternity care should be adopted across all facilities. Yes, I think that is good. Thank you so much for that comment. And this is our hope that we shall adopt slowly all the components of respectful maternity care and be able to achieve this within our settings. I think that is all. Thank you, Dr. Karingo.
Thank you very much, Elizabeth. And I really want to thank the panel, the speakers that were availed themselves. This was a very interesting conversation, and we've even gone beyond our time. But I think it was necessary for us to listen to these presentations and also just to get to share what's happening. After this, I'm hoping that we will all give respectful maternity care to our clients. So once again, I want to thank you for joining our first webinar of the Person-Centered Respectful Maternal Care webinar series. Our next webinar will highlight the work of the Innovations for Choice and Autonomy project funded by Bill and Melinda Gates Foundation that will focus on Nigeria, Kenya, Uganda, and Malawi, and will involve developing a new quantitative measure of contraceptive autonomy, enhancing tools to support contraceptive decision-making and self-ejection through a human-centered design approach, evaluating the effectiveness of user-centric support tools and assessing the localized impact of provision of self-injection on contraceptive uptake, decision-making, and autonomy. Stay tuned for more information regarding the date and time of the next webinar. Thank you very much for attending this webinar.
Thank you.
Bye.
Thank you. Bye.
Bye. Happy Easter.
Bye, thank you.